This program is brought to you by the University of Michigan. For more information, visit umich.edu.
The University of Michigan Division of Gastroenterology and the Inflammatory Bowel Disease Program host the IBD Visiting Professor Lecture Series in Ann Arbor, Michigan. This series presents the latest in clinical research and basic science from IBD experts from around the world.
Well, it's great to be here, and as Peter was introducing me, I heard days are numbered and tornado in the same sentence, and then my name, so I'm wondering what that all means. Hopefully that's not going to portend anything going forward. But thank you for having me here, and again to Peter, thank you for inviting me. I was able to take a tour of your facility yesterday, and I was impressed how big, I thought Pittsburgh, how big Michigan is. So truly an impressive place with a lot of buildings, and more buildings I understand underway. So as Peter said, and hopefully I don't know if people can see this, but Peter mentioned I'm going to really cover the aspects of postoperative Crohn's disease, mainly from a clinical standpoint, but in my last slide I will mention some of the interest we have in looking at genetics, the microbiome, and some of the physiology of post-op Crohn's. We actually just assembled a group last week at our university, and we're planning to put in a U award for post-op Crohn's in a natural course of disease that has nothing to do with treatment. But today I'm going to focus more on the clinical aspects. Let's see. For some reason, let's see. Hopefully I don't have to do this for every slide. Yeah, that's what's not working. And again, okay, there we go. For some reason it seemed locked up. So I think that all of you are familiar with these treatment paradigms for inflammatory bowel disease, where traditionally the medicines we had used at the lowest part of the pyramid were what we considered the safest treatments, and then we went up to more aggressive immunomodulators, anti-TNFs, and then surgery was on top. Interestingly, one of the aspects that we're now looking at for a defined group of Crohn's patients is maybe we should be going to surgery earlier in their course. Maybe their disease by the time we meet them is too far gone in terms of stricturing and fibrosis that actually inverting the pyramid and starting with surgery may be more relevant. We're not there yet. There is a German study actually looking at this. We have a small pilot study looking at first onset of treatment being surgery, followed by different parameters of medicines, whether it be anti-TNF or immunomodulators after. I really hope I don't have to do this the whole time. I apologize. The question is whether or not our increased use of immunomodulators and anti-TNFs has decreased the need for surgery over time. And there are limited prospective data, and we do have a couple of retrospective studies looking at this. You're probably familiar with the study out of Paris that looked at the impact of increasing use of immunosuppressive therapy in Crohn's disease and intestinal surgery. And without going through the study too much in detail, what this group found is despite the increased use of Imuran and 6-MP, there was still a high rate of surgery. We actually published our data last year looking at small bowel resection rates and a similar cohort, but also included anti-TNF therapy. And we collaborated some with Mount Sinai in New York as well. And we looked at nearly 3,000 patient charts for patients with Crohn's who underwent surgery. We included all the typical medicines that you would see as far as treatment for IBD, looked at disease behavior, and then broke these down into different cohorts in time, from a 1995 cohort up to 2007. And what we found is that the time periods are each bar. Across the bottom you can see 5-ASA, immunomodulators, anti-TNFs, and corticosteroids on the far right. And as you can see, and not surprising for those physicians treating IBD, is that there is an increased use of immunosuppressives and anti-TNF over time, and somewhat of a flattening or a decrease in 5-ASA and corticosteroids. So our question was, were we seeing a different rate of surgery in these patients receiving more immunosuppressive therapy and anti-TNF at the University of Pittsburgh? And interestingly, at least based on our study, we did not find that the increased use of anti-TNFs and immunosuppressive therapy made a change in the outcomes as far as rates of surgery. Now, one very important caveat is that part of this may be limited in the time by which immunosuppressives and anti-TNFs were started, meaning that if the disease is too far gone, surgery is probably inevitable anyway. And I think as we look at the data in natural course of Crohn's disease, that's an important factor to keep in mind. Nonetheless, we found that the surgical rates were fairly flat across time. So what does this mean? This means that at least right now in 2011, despite IBD medicines, still nearly 2/3 to 3/4 of our Crohn's disease patients will undergo a resection in their lifetime. Those are data that have been well published even in recent natural course of disease studies from large centers, and is something that we've seen as well. We know that surgery is not a cure. These are data by Paul Rutgeerts and others from the early 1990s, where we know that if you do nothing at all, you take a patient who undergoes a resection, they have an ileocolonic anastomosis, so the slate is wiped clean, they have no active Crohn's disease, and you do nothing else, that in 3 years, 30% of patients are starting to manifest symptoms of Crohn's disease, and that by 10 years, nearly 2/3 of the patients are having symptoms. Somewhat alarming is that based on how the endoscopic appearance is after surgery, nearly 90%, 70 to 90% of patients 1 year after surgery will have endoscopic recurrence. They may not feel this, and I'll come back to this entity of clinically silent Crohn's disease, but the endoscopists in the room know that if you have a patient with an ileocecal resection and anastomosis, usually there's a honeymoon period up to 5 years where they feel absolutely wonderful. But if you do a colonoscopy, look at their anastomosis and neoterminal ileum, there's a surprisingly high rate of ulcers and inflammation. Probably even more surprising, and this was again based on the Belgium data, is the histologic recurrence occurs as early as 1 week after surgery. And there are some fairly elaborate studies, which I won't go through, but in essence, what they looked at is the neoterminal ileum above an anastomosis, taking biopsies and finding that as early as 1 week after an anastomosis, there is already Crohn's that's starting to recur. So patient may not feel it, we may not see it early, but there's already Crohn's disease occurring. And this is getting into the whole interest we have in linking genetics with microbiome, and this is the big grant that we're putting forward for a postoperative model. Well, again, coming back to Paul Rutgeert's data, can we predict which patient will have Crohn's disease and complications of Crohn's disease postoperatively? And in essence, he came up with a scoring system that I think most of us in IBD are familiar with as far as looking at postoperative recurrence. And in his study, he took patients who had an anastomosis. 1 year after surgery, they underwent a colonoscopy, and then they came up with a score from 0 to 4. In essence, a 0 is normal, 1 is less than 5 ulcers that are seen in the neoterminal ileum, 2 is more than 5, and then 3 and 4 are more significant inflammation and scarring. What was then done is he looked at what happened to these patients who had these degrees of inflammation then long term. And these are just to show you some of these scores. For those that are involved in the PREVENT study, you've probably seen these before as examples of some of the scores that we use. So on the top, it would be a score of a 1. So less than 5 ulcers in the neoterminal ileum. A 0 would be completely normal. 3 and 4, I think most of us are familiar with seeing this in patients not just with surgery, but Crohn's disease would represent what we would consider more moderate to severe, and certainly that bottom one, the 4, we can start to see that there's already stenosis.